So our topic is penicillins. So there are 5 types of penicillins: natural penicillins, penicillinase resistant penicillins, aminopenicillins, carboxypenicillins, and uridopenicillins. So these are the 5 types of penicillin. First, before we go into these penicillin groups separately, first we'll talk about some general properties of penicillins. When you talk about the structure of penicillins, right? If you remember my beta-lactam introduction to beta-lactam antibiotics, right? So beta-lactam, these are beta-lactam antibiotics. Penicillins come under beta-lactam antibiotics. So they have a 4-membered beta-lactam ring. Like all the other beta-lactams, penicillins also have the 4-membered beta-lactam ring. Then there is a 6-amino penicillinic acid nucleus, right? So that is 6-amino penicillinic acid that has a beta-lactam ring, and then there is another 5-membered ring called thiazolidine ring. So that it has 2 rings. Beta-lactam ring because it's a beta-lactam, then also penicillin specific 5-membered ring, we call it thiazolidine ring. So those 2 rings are there. Additionally, there is a side chain attached to the 6th carbon position in the beta-lactam ring. That is the side chain. So side chain determines the antibacterial spectrum and the pharmacological properties of the penicillin. So side chain is the one that determines the antibacterial spectrum and the pharmacological properties of different penicillins. This is the picture of this. You can see this is the thiazolidine ring, right? This is the beta-lactam ring, right? So this is the side chain. This is the side to the here. This is the side chain to the 6th position attached to this. That is the side chain, right? That is the one that determines the structure of the side chain. Determined by changing this side chain, yeah, scientists they produce different penicillins. So that is the previous one is 6-amino penicillinic acid, right? We call it penicillin nucleus, right? This is structure is 6-amino penicillinic acid or penicillin nucleus. This is 6-amino penicilloic acid. You can see this bond is broken down, right? So that means bacterial beta-lactamases have come here and broke this bond, right? So this is inactive. Beta-lactam ring is inactive. So this is inactive form of penicillin. We call it penicilloic acid. 6-amino penicilloic acid. It is the inactive form, right? Destroyed by the beta-lactamase. So we'll talk about the excretion of penicillins. Penicillins are excreted by the glomerular filtration and tubular secretion. Right? Look at this picture. Penicillins are mainly excreted by glomerular filtration. That's why I put 2 arrows. Right? Then also there is tubular secretion on just 1 arrow. But anyway, it's an important secretion, right? So penicillins are excreted by glomerular filtration and tubular secretion, right? These are from the Bowman's capsule. This is Bowman's capsule. Then afferent arteriole comes, right? Glomerular capillaries, then the efferent arterioles, right? And then the arterial nectars are there, right, around it. So from there, this tubular secretion and glomerular filtration occurs, right? So that is how the penicillins are excreted through the kidney, right? There is a drug called probenecid. It blocks the tubular secretion. That is why it can be used to increase the half-life of penicillin in the blood. So probenecid increases the half-life of penicillin in the blood by blocking the tubular secretion. So that is why we can use probenecid to increase the penicillin concentration in the blood, right? So for serious infections we use probenecid, right? With the antibiotic you use probenecid. So the antibiotic excretion is diminished, right? So we have higher concentration of antibiotics, right? They are very popular those days, but now when the antibiotics are not much available, we use it a lot. Now we don't use that much because there are a lot of other antibiotics, but we still use. So the other thing is tubular function is not fully developed in neonates and low birth weight infants, premature infants, low birth weight infants, neonate. Tubular function is not developed. So tubular secretion is low. So that means when you give a penicillin, there is higher concentration of penicillin in blood because tubular secretion is not effective, right? So you in this group of patients like neonates, low birth weight infants, we have to use low doses of penicillins, right? We have to modify the dosage, So when we talk about the side effects of penicillin, right? Penicillin is a hapten, low molecular weight substance, less than 5,000 daltons. It can't work on its own. Right? They are low molecular weight. They are not immunogenic. They can't elicit an immune response on their own. Smaller molecules, less than 5,000 daltons. But when it enters our body, right, maybe orally, maybe injection, it combines with our protein molecules, carrier proteins, right? Hapten, carrier protein combination produce the immunogen. Right? Then when it becomes an immunogen, it can elicit an immune response on its own. It can elicit an immune response on its own when it becomes an immunogen. So that's what happens when you take penicillin. It can produce immune response, right? There are the more major side effects of penicillin are the hypersensitivity reaction. If you remember, you know 4 types of hypersensitivity, right? In immunology, type 1, type 2, type 3, type 4. Penicillin can produce all types. Type 2 is antibody-mediated hypersensitivity, but I didn't include it here. It is not very common. Type 1, 3, 4 are the most common. Right? Type 1 is very common. Right? It can produce anaphylaxis, type 1 hypersensitivity, which is very serious. Right? That is, if you remember, IgE mediated. Right? IgA deposit on mast cells. Right? Then when the penicillin bind, the cross-link the IgE molecules on the mast cells, mast cell degranulation occurs. Right? It can be fatal. Type 3 hypersensitivity, right? That is immune complex mediated disease, right? Immune complexes get deposited in blood vessels, joints, in skin, right? They produce fever, urticaria because deposition of immune complexes in the skin, arthalgia, deposition in the joints, and angioneuritic edema, again deposition in the blood vessel walls, angioneuritic edema. Right? So that is type 3 hypersensitivity. Type 4 hypersensitivity, that is exaggerated cell-mediated immune response, exfoliated dermatitis and Stevens-Johnson syndrome. Right? So those are the hypersensitivity side effects. Then there are other side effects. Interstitial nephritis is a very common side effect of penicillins, right? Especially with methicillin those days, we discontinued methicillin because of these side effects. But any penicillin can produce interstitial nephritis, right? What are the features of interstitial nephritis? Fever, eosinophilia, eosinophil count goes up in blood, proteinuria, protein excretion in urine, eosinophil eosinophils in urine, hematuria, blood in urine. Right? So when the drug is discontinued, renal function returns to normal. Right? That is interstitial nephritis. Then it can produce antibiotic-associated colitis, right? Famously known as pseudomembranous colitis, produced by Clostridium difficile. Right? What happens is when you take penicillins, right? Normal flora are killed. Clostridium difficile, which is antibiotic resistant, they will overgrow. But they produce a cytotoxin that produce diarrhea and pseudomembrane formation, pseudomembranous colitis, right? So that is antibiotic-associated colitis, right? So that's another one more side effect. Then also seizures, especially when there are higher concentration. If you give penicillins to renal failure patients, they are at higher risk of seizure because their excretion is poor, right? The concentration goes up in the blood, seizures. So that's a side effect, especially when the blood concentration goes up. So now we'll talk about the groups, different groups of penicillin. Natural penicillins, right? They are naturally formed penicillins, right? Penicillin notatum fungus, right? So there are 2 types of penicillin, penicillin V and penicillin G. Penicillin V is also known as phenoxymethyl penicillin, no oral penicillin. It's available as sodium salt or potassium salt. Right, and it is acid stable. That's why you can't take it oral. Right, it is not destroyed by gastric acid barrier, so it can be taken orally. Right, it is taken as used as sodium salt or potassium salt. That is oral penicillin. Then penicillin G is acid labile. That's why we give it parenteral injection. Right, you can't take it orally, acid labile. Right, there are 2 forms of penicillin G. Aqueous penicillin G and reposited forms of penicillin G. Aqueous penicillin B water soluble, right? This is the one you can give intravenous, water soluble, right? But these are deposit form, they deposits, repository, right? Long acting forms. You can't give them intravenous, only intramuscular. only intramuscular. So we'll talk about the aqueous penicillin or crystalline penicillin or benzyl penicillin. Crystalline penicillin or benzyl penicillin. So they can give intravenous, intramuscular, subcutaneous or intrathecally. That is intrathecally subarachnoid space, right? When there is a CNS infection, right? We give intrathecal, right? That works fast. Right. So those are the aqueous penicillin. The repository forms of penicillins G include benzathine penicillin and procaine penicillin. Procaine penicillin, that is procaine plus penicillin, longer half-life. Benzathine penicillin, very long half-life. Right. But remember, only intramuscular. Right. You never give intravenous because they are not absorbed. They are not soluble. Then about procaine penicillin. So the procaine penicillins are equal molar parts of procaine and penicillin. They provide adequate blood levels for 12 to 24 hours. Adequate blood levels for 12 to 24 hours. Benzathine penicillin is a mixture of 1 mole of penicillin G with 2 moles of ammonium base, right? But it has adequate serum level for 30 days, right? Remember, procaine penicillin only 12 to 24 hours, right? But benzathine penicillin 1 month, 30 days, right? That's why we use it for a lot of situations, rheumatic fever, right? Benzathine penicillin. We give benzathine penicillin 1 injection every month to prevent recurrences. When the patient gets rheumatic fever, you don't want to have the patient to have another attack of rheumatic fever because it can, damage the heart further. So you prevent rheumatic fever by giving benzathine penicillin. That will kill any streptococcus pyogenes, right? So what are the clinical indications of natural penicillins? Number 1, Streptococcus pyogenes. Streptococcus pyogenes sore throat, right? Streptococcus pyogenes skin infections, maybe impetigo, right? Necrotizing fasciitis. Any Streptococcus pyogenes infection, drug of choice anywhere in the world, penicillin. Penicillin resistance is very, very uncommon, unheard of, almost unheard of. There have been few cases, but it is almost unheard of. So you can close your eyes and give penicillin for Streptococcus pyogenes. Right. Group B Streptococcus that produce neonatal sepsis, neonatal septicemia, right? Neonatal meningitis, right? Streptococcus agalactiae, that is group B Streptococcus. Drug of choice, penicillin. Drug of choice, penicillin. Works very well. Viridans streptococci, oral commensals, right? Viridans streptococcus. It's a group of Streptococcus mutans, sanguis, right? Those are groups of Viridans streptococci. So they can, if they enter the bloodstream, if the patient has heart lesions, right, congenital heart disease, they can get deposit on the damaged heart valves and produce subacute bacterial endocarditis, SABE, subacute bacterial endocarditis, right? Viridans streptococci. What is the treatment? Breast drug, penicillin, but we combine with aminoglycoside because of the synergistic effect, right? Penicillin works on the cell wall. Penicillin works on the cell wall and make the cell wall weak because it prevent the cross-linking of peptide ligands. Cell is weak, penicillin will enter. So not penicillin, then the penicillin make the cell wall weak, aminoglycoside will enter and bind to the 30th ribosome subunit and inhibit protein synthesis, right? 2 birds in 1 stone, right? You give both antibiotics together and synergistic effect. Penicillin break down the cell wall, make the cell wall weaker, aminoglycoside enter and inhibit protein synthesis. That is synergistic effect, right? Then penicillin sensitive to Neisseria meningitis. Neisseria meningitis, why penicillin sensitive? Because those days Neisseria meningitis was almost 100% sensitive to penicillin, but now they have developed resistance. So when the patient with Neisseria meningitis comes, it's a serious infection, right? That produces meningococcal meningitis or meningococcemia, right? And that's a life-threatening infection. So when the patient comes, if you suspect, if the gram stain shows Neisseria meningitis in the CSF, or right in the CSF, right? So what do we do is we start ceftriaxone, which is antibiotic, but we don't start penicillin. We don't know if it is penicillin resistant, right? So that's why we start empirical ceftriaxone, right? If the blood culture report, the antibiotic sensitivity report come in 48 hours, 2 days. So if the report says penicillin sensitive, yes, stop ceftriaxone, start penicillin because penicillin is the best drug for Neisseria meningitis, right? So we start ceftriaxone, if the antibiotic sensitivity report says it is sensitive to penicillin, we change to penicillin because it is the best drug. Then penicillin sensitive streptococcus pneumoniae, yes, penicillin. But actually this one, penicillin pneumoniae becoming where they have very high percentage of resistance to penicillin now, streptococcus pneumoniae, that produce meningitis and pneumonia. Right? If in pneumonia patients, we commonly use vancomycin. Right? If it's empirical treatment, pneumonia patient, you don't know the sensitivity, but you know it's streptococcus pneumoniae, most likely you give vancomycin. If the culture report says its sputum culture report comes and antibiotic sensitivity is penicillin sensitive, start penicillin, stop vancomycin. Right? That's important. Then Treponema pallidum, syphilis. Right? All stages of syphilis except neurosyphilis, drug of choice is benzathine penicillin, long acting one, 30 days. Right? Long acting one, but you give more frequently actually, right? Intramuscular. Primary, secondary, latent, right? We give only one dose of benzathine. That's it. Tertiary syphilis, other tertiary syphilis, except neurosyphilis, gametal syphilis, cardiovascular syphilis, right? We give again benzathine penicillin. But neurosyphilis, we give benzyl penicillin because neurosyphilis is a serious manifestation. Right? You're going to give higher concentration of penicillin more frequently, right? So you give benzyl penicillin can be given every 4 hours or every 6 hours intravenous, or maybe intravenous infusion. Right? That's how we treat neurosyphilis. Right? So those are the clinical indications. Remember, never use penicillin against Staphylococcus aureus. It's almost close to 100% penicillin resistant because they all produce penicillinase. They all produce penicillin. So never prescribe penicillin, natural penicillins, right, against Staphylococcus aureus. And also they don't have gram-negative activity, so don't use them for gram-negative infections. Then penicillin, resistant penicillin. So if you remember the history, right, in 1940s, early 1940s, I think around 1944, we started 1942. It was discovered, but we started using 1944. It came out as a drug in around 1944. So we started to use penicillin. Within less than 2 years, Staphylococcus aureus became resistant to natural penicillin. Why? Because they started to produce penicillinase. So what did we do? We didn't give up. We produced penicillinase resistant penicillins. How does it work? Right? So this is the beta-lactam ring. This is the thiazolidine ring. Right? This is the side chain. Right? We produce penicillin resistant penicillin. How? We modified the side chain. We gave a very big side chain, long and big side chain. Right? What does it do? The structure is like this. It protects this beta-lactam, this bond. This is the bond that is broken down by the beta-lactam antibiotics between carbon 7 and nitrogen. Right? That bond is protected by this large molecule. Right? That is how penicillinase resistant penicillin works. Right? So they are effective against methicillin susceptible strains of Staphylococcus. Remember, methicillins are, because that we will talk in a different lecture, how to interpret methicillin susceptible strains, how to identify methicillin resistant strains. But remember, penicillinase resistant are effective only for methicillin susceptible strains of Staphylococci. Methicillin susceptible strains of Staph aureus. Methicillin susceptible Staphylococcus aureus. Methicillin resistant Staph aureus, it doesn't work. None of the beta-lactams works except the fifth generation cephalosporin. Right? Fifth generation ceftaroline, ceftobiprole, those are the fifth generation. Other than that, we'll talk about those things under cephalosporins. Right? They don't work. None of them work for MRSA. Right? So if it is MRSA, we have to use vancomycin, linezolid, daptomycin, those things. Right? So penicillin resistant penicillins, right? We are talking about the first penicillin resistant penicillin we started to use was methicillin, but methicillin produced lot of side effects, especially interstitial nephritis. So we stopped methicillin. So we don't use methicillin as a drug. We use it for antibiotic sensitivity testing to identify methicillin resistant Staph aureus from methicillin susceptible Staph aureus. We have a culture plate, we inoculate the organism, put the methicillin dish like this. The red dish is methicillin. So this is methicillin resistant Staph aureus because it doesn't inhibit growth of Staph aureus. You see, it has gone to the edge of the antibiotic dish, red dish. Here there is a shown of inhibition. You see this? Shown of inhibition, that is methicillin sensitive Staph aureus. Right? So remember, it is methicillin is not a drug now. Used only for antibiotic sensitivity testing. This is the drug that is being used. Nafcillin is being used a lot. Right? Is used only available for IV administration because oral administration and parenteral intramuscular administration, intramuscular absorption and oral absorption is erratic. So we use only IV. Drug is highly protein bound and also it is excreted mainly by the liver. It is metabolized and excreted by the liver. So that is the important thing because all the penicillin mainly excreted by the kidney. But this is nafcillin. Nafcillin is excreted by the liver. So that's why you can use without any problem for renal failure patients. Renal failure patients, don't worry, nafcillin can be used. But when it comes to liver failure, you have to be careful. Then there are other penicillin resistant penicillin, that is isoxazoline penicillin, isoxazoline penicillin, gloxacillin, flucloxacillin, dicloxacillin. Right? Cloxacillin, dicloxacillin, flucloxacillin are available for oral use. Right? And the absorption is significantly affected by presence of food. Right? So they are given before meals. Oxacillin, flucloxacillin are available for parenteral use, injections. Right? Oxacillin is very popular actually. Oxacillin is also very popular. It has a high incidence of hepatotoxicity and rash. Oxacillin. Then aminopenicillins. So aminopenicillins, you can imagine, right? Side chain, there is an extra amino group. Extra amino group attached to side chain, right? But they are also not stable against beta-lactamases. They are also inactivated by penicillinases. Right? But they have little more active because of the amino group. Their spectrum is little more than the natural penicillins. So they have more gram-negative activity. Right? Community-acquired E. coli. Remember, hospital-acquired E. coli are resistant to aminopenicillin because they have come across all sort of antibiotics in the hospital and they have developed resistance. So community-acquired E. coli, they are not, familiar with most of the antibiotics. So they are susceptible. Shigella sone, the shigellosis, right? The mild form of shigellosis, Shigella sone, respond to ampicillin, aminopenicillins, right? So they have little, you can use in certain mild gram-negative infection, not serious gram-negative infections, aminopenicillins. They also affect active against enterococci, but there is enterococci resistant, ampicillin resistant enterococci are there. Then we use vancomycin, but vancomycin resistant enterococci are also emerging now. Right? So the antibiotic resistance is a big problem now, right? So there are two under aminopenicillin, there are two aminopenicillins, ampicillin and amoxicillin. Ampicillin is available for oral and parenteral use. Right? Ampicillin is good absorption now after oral administration, but when there is food, absorption is reduced by 30 to 60, more than 30%. It is absorption is reduced. Right? So food reduces the absorption. That is why you have to take it on empty stomach. Right? And it's very effective for Listeria monocytogenes, right? As I neonatal septicemia, neonatal meningitis, we always had ampicillin. Why? Listeria is a possibility. E. coli, group B streptococci, Listeria. Those are the three organisms, right? Escherichia coli, group B streptococci, Streptococcus galactiae, and Listeria monocytogenes. Right? To cover Listeria, we give ampicillin. Right? Ampicillin also we combine with aminoglycoside for Listeria infections, right? For synergistic effect, ampicillin combined with aminoglycoside is commonly used, right? Remember, ampicillin make the cell wall weak, and then the aminoglycoside can enter and inhibit protein synthesis, right? That's how we call it synergistic effect. So diarrhea is a common side effect of ampicillin. Ampicillin, we call it ampicillin diarrhea, right? Amoxicillin, they have a hydroxyl group in the side chain. In the hydroxyl group, this is the important thing. It doesn't retard the absorption. Food doesn't affect the oral absorption. So that's why It is very popular. You can take any time, before meal, after meal, well absorbed than the ampicillin. And also diarrhea is less common. Diarrhea is less common. So it is more bioavailability and better tolerability, right? Better tolerability. Then carboxypenicillins. Carboxypenicillin, they have a carboxyl group attached to the beta-lactam ring, to the side chain, carboxyl group, right? Only those days we use carboxylin, it is not available because of the side effect. They the only one, ticacillin was the only one available of carboxypenicillin, right? It's a very popular drug anyway, right? It's a parenteral medication. You have to give injection, right? It is combined, sometimes it's combined with clavulanic, ticacillin clavulanic combination. Clavulanic acid inhibit beta lactamases so that it will be effective for beta lactamase producing strains, right? Ticacillin clavulanate, right? Clavulanate will inactive beta lactamases. Good gram positive cover, but inactive against enterococci. Okay, it has broad spectrum of activity against gram negatives, including Pseudomonas aeruginosa. It has broad spectrum of activity against gram negatives, including Pseudomonas aeruginosa, but the activity is less than the piperacillin is better for Pseudomonas, but this is also commonly used, tricacillin, right? So it has good gram positive cover and good gram negative cover, including Pseudomonas, right? The common side effect is it can produce bleeding tendency. Why? It binds to the ADP receptors on platelet. Remember, ADP receptors on platelets are important in platelet aggregation, right? To prevent bleeding, platelet aggregation, ADP receptors. But ticacillin bind to the ADP receptors. Ticacillin bind to the ADP receptors and prevent platelet aggregation, right? That can produce bleeding tendency, right? Ticacillin. So that is why we have to be very careful if you give people with bleeding tendency, ticacillin, right? So especially because occurs when the ticacillin level is high, right? Such as patient with renal failure, right? There is if you give ticacillin to a patient with renal failure, less secretion, so it can be toxic, right? It can bind to ADP receptors and prevent a platelet aggregation. The balance of preventing bleeding is lost. Uridopenicillin. So they have a urido group attached to the side chain. Urido group, very large molecule, urido group, right? So uridopenicillin and carboxypenicillin, we call it actually anti-pseudomonal penicillins, right? Because they work for Pseudomonas aeruginosa. Carboxypenicillin is ticacillin. Uridopenicillin actually it is piperacillin. There were 3 uridopenicillins: piperacillin, naclocillin, mesclocillin are no longer available because of side effect. But piperacillin is the only one very popular, right? It has very good spectrum. You will understand when we talk about here. Uridopenicillins, very good gram positive activity, including streptococci. Very good gram positive activity. Very good gram negative activity, including Pseudomonas aeruginosa, right? More than ticacillin effect, right? And very good anaerobic coverage. So this is gram positive cover, gram negative cover, anaerobic cover. So it covers a whole range of organisms, right? That's why when you give empirical antibiotic in hospital patient, right? Severe infection, we don't know where the infection is originating. We know there's an infection, but we don't know what type of bacteria. It starts piperacillin, right? Because it covers all most gram positives, most gram negatives, and including anaerobes. Then also it can be synergistic with aminoglycoside, right? And also piperacillin can be combined with the beta-lactamase inhibitor such as tazobactam. Piperacillin tazobactam combination, because tazobactam will inactivate beta-lactamases produced by bacteria, right? So the tazobactam piperacillin can do more effect, right? So piperacillin tazobactam is very popular, right? Shosin is the brand name, right? Shosin is the brand name. So that's all about the lecture. I hope you enjoyed the lecture. Okay, thank you. If you found this video helpful, please like this video and subscribe to my channel. You can get new video notifications by clicking the bell icon. My Patreon supporters can request lectures and get exclusive content. Please check the description for links and more details. Thank you.